Thank you very much. Good morning. I'm very happy to be here this morning in Montreal. Chilly city as well. Got a little lost on the walk up, but managed to find our way. Got distracted by lots of nice shops and sites and buildings. So I'm here this morning to give you an update on non-invasive ventilation set up by the nursing service in the Irish Multidisciplinary Clinic. My colleague Bernie Corr, which many of you will know, originally presented this I think nearly 10 years ago in Belgium, so I'm giving you an update 13 years on. I hope I get the tech working appropriately. The green button. So I didn't get it working well. Okay, so by way of background, Ireland is a small country on the west of Europe, sorry, got the very basics wrong, with a population of almost 5 million. We cover the Republic of Ireland. The lifetime risk of developing motor neuron disease in Ireland is about 1 in 300, the incidence being 2.7 per 100,000. And we currently have closer to 450 people with motor neuron in the Republic of Ireland. The National Motor Neuron ALS service was set up back in 1994 by Professor Orla Hardiman. It was the first multidisciplinary clinic in the country and now offers an extensive outreach program with teaching, training, research, and is well known internationally. In 2010, as a result of financial constraints and the lack of access to inpatient admissions, the nursing service, primarily then was Bernie Corr with the backup of the Irish Motor Neuron Disease Association, started setting up non-invasive ventilation remotely in patients' place of residence, be that their homes, other regional hospitals, hospices, or nursing homes. And this was as a direct result of not being able to get inpatient access or access to beds, which remains to be an issue in Ireland. So this presentation will give you an update on how that service has developed over the recent years. So by way of background as well, our clinic, multidisciplinary in nature, Professor Orla Hardiman runs it, supported by another neurologist and several other registrar teams. We used to be Bernie Corr, which many of you I know will know. There is now 6 nurses on that service, 2 advanced nurse practitioners and 4 clinical nurse specialists. And we are supported by the Irish Motor Neuron Disease Association, and they now have a team of up to 4 nurses. You will also see there, I skipped slightly through that, we currently now have access in our service that has grown over the years to psychology, social work, physio, respiratory technician, not currently, but it is a goal. We link all our patients with palliative care service in the community, occupational therapy, speech and language, dietitian. So it really is a wide range of interprofessionals that we work with. And this is our carer dyad, so our patients at the centre of it, and we will care for them in their place of residence, be it home, residential care, acute setting, and the multidisciplinary service aims to meet them and interact with the community services there as well, wherever they really need it. So about 80% of Irish patients with motor neuron and ALS attend the national service. This is kind of for multiple reasons. It is a small country relative to lots of other places internationally. However, it's quite a journey, 300 miles north to south, 150 miles east to west. But there is smaller clinics available in Galway in the west, and there's a clinic in the south. But still, most of our patients will attend the service, and we run a national service as a result of that. But it's also to access trials, which Professor Hardiman runs. About 160 patients are diagnosed each year. And I told you about our nursing service. So, as well recognised and accepted, most patients with ALS MND die from respiratory failure. And one of the distinguishing features is how well people will, if they're offered, and how well they do on non-invasive ventilation. So, like I mentioned, in 2010, we started doing this in the home setting because we couldn't admit patients to the hospital setting to get them a trial of this. So home and clinic reviews make us aware of the patients that require or when they're suitable patients for non-invasive ventilation. We follow the NICE guidelines with a SNP of around 50 or FVC dropping as well as monitoring for clinical symptoms. And our outreach programme allows us to regularly review our patients in their settings. We interact closely with our community colleagues and other interprofessionals, so we're aware of their symptom burden and how they're progressing, and we have an open door policy when it comes to contacting us through phone calls with the interprofessionals, with the team, with the caregivers, with families, and we ourselves do regular home visits. From a respiratory point of view, from a remote monitoring point of view, we do send out pulse oximetry. Our physio colleagues can do remote FVCs, and these assessments ensure that patients are identified and offered a timely trial of non-invasive ventilation. And we have their care needs tailored to meet their symptom burdens. So this is just a little bit of data on the amount of pulse oximeters in recent years, that it's growing all the time. The outreach element of this kind of grew as a result of COVID. I suppose we were able to get more pulse oximeters and remote monitors to send out. So it has grown from 2020 to 41 to 108 in 2023. And then the bottom set of figures there that you will see, that there was just 10 patients set up in 2010 when it was just Bernie on her own. And 2023, we haven't finalised our figures for this year yet, 93 patients were set up on non-invasive ventilation. And just to comment, as part of our COVID response, our colleagues in the Irish Motor Neuron Disease did set up non-invasive ventilation with our patients in their homes as well. So the figures reflect this. So the benefits of setting up the non-invasive ventilation service: patient comfort, symptom management, better quality of life, particularly in the home setting or in their place of residence. Feedback, and what we find is that it certainly facilitates important discussions around acute crisis management and end-of-life discussions, allows us to form important rapports and professional relationships with our interprofessional teams in the communities. It is in line with our current health policies within Ireland for integrated care programmes with the community. And there's huge financial savings, which have been known, and that's really what facilitated Professor Hardiman's service to grow, that we could prove the financial cost savings there. So there's significant, as I said, significant evidence that NIV reduces ventilatory failure in these patients or supports it. Setting it up in the home reduces the need for hospital admissions. I felt it was important to outline that because there still are services within the Republic of Ireland that do admit acutely to the hospital setting to start non-invasive ventilation. Obviously, there's a financial burden of this, but there's a burden for the patient to leave their home setting, for care needs. An acute setting, we find, isn't the place to care for these patients, or isn't the ideal place to care for these patients. The cost saving is estimated to be about 80,000 per annum. And as I mentioned, home-based end-of-life discussions can avoid emergency admissions and unplanned initiation of possible invasive mechanical ventilation. And the cost saving of that in our setting would be approximately 13 million per annum. So recommendations to our colleagues in the field. We feel that the nurse outreach service has resulted in an increase of home visits and the number of non-invasive ventilation setups, and a significant reduction of our patients' acute admissions. The home initiation, as I said, enhances end-of-life discussions and reduces the need for admissions to an acute hospital setting. Thank you very much for your time. I probably spoke a little bit quickly and caught you by surprise there.
Well, caught me off guard. All right, so this is open for questions now. Thank you very much. Yeah, we'll just let you know it's very hard for us to see you guys up here because there's lights in our eyes, but.
Hi, I'm just wondering, what is your process if patients require additional therapy like mouthpiece ventilation, or like do you offer?
Yes, we do. My colleague Deirdre Murray is here, one of our outreach physio program, and it has grown in recent years. And yes, it is something that we do as an outreach service now as well. Well, they may be assessed in clinic, like we were open to which meets our patients' needs best. But yeah, we have a number of patients on mouthpiece ventilation, and obviously usually they would have both be assessed by physios, and then the nursing service or the physio team will go out and set up in the team. But certainly growing, and patients have found it a huge quality of life initiative, gives them great choice. Yep.
Thank you.
Hi everyone, I'm Dr. Zuccarino from Italy, ALS Association of Italy. I have a question for you. Congratulations for your job. I was wondering, when you just show us setting up the non-invasive ventilation, when you go at home, you are just you, or you are a little team for setting all parameters in the machine?
So a member of the prescription would come from clinic, from Professor Hardiman or one of the medical teams, or we have a respiratory physician that backs the clinic as well. So the prescription is preset. Respiratory technician from the company that we use, Respicare, but there are a number of different companies in the country, but Professor Hardiman and our clinic links with a company called Respicare. So we go with one of their technicians or nurses. They will go through the care of the machine, processes like that, and then from a nursing point of view, we educate the patients on the benefits, the reasons, the care, the use, and the possible implications for their illness. And then obviously it facilitates, like I discussed, end-of-life discussions, discussing ventilation, different types of ventilation, what to do in an acute crisis, things like that. But practically, it's a nurse usually from our team, from the multidisciplinary service, and then from the company that supplies the machine. The machine is funded by the Irish healthcare system, and most patients in Ireland get a medical card, and any long-term chronic conditions are paid for by the government through this medical card.
Anyone else? Yes.
Hi, David Busek, a patient fellow. So I know that my own BiPAP has remote monitoring capabilities. So I'm curious whether you have any people who are monitoring the different patients' usage and providing any kind of real-time or semi-real-time feedback on how, whether they need changes or how things are working for them.
I'm aware that this is some other companies in the country certainly have this, if patients go on it privately or maybe from some of the other clinics. Our clinic currently doesn't do it, but it is possible. And it is something that, that each machine can have a chip and it can be monitored. We send out pulse oximetry quite regularly. As I mentioned, we see our patients either from an outreach perspective or in clinic, probably 8 weeks. You know, we did aim for 6 to 8 weeks. There is an interaction at least every so often. And we do have a telemonitoring interactive, one of my other colleagues is here, system where patients can feedback how they're doing as well. So there's multiple different, I suppose, technological ways that we're trying to get in, current to day-to-day feedback from our patients. But it is possible with the service that we run as well and the machine that we use. It's not currently that we're doing it routinely, but it is possible.
Okay, there's one way in the back corner.
Hi, good afternoon. My name is Donna Sickles. I'm a respiratory therapist with the ALS Hope Foundation in Philadelphia. My question is, you're going out to the patients' homes with settings that are already preset on your NIV?
Correct, prescription.
So what if the patient needs more or less, or they're not comfortable with it? So
a little bit like the last person's question. We do follow-up monitoring. We do keep in touch with how it's tolerated, how people are doing well. The beauty of the nursing services is we see these patients regularly. So routinely, if I set up a patient in the community, I am most likely in touch with them within a week and most likely seeing them again within a month. And we can change the settings without any big issues, sometimes remotely, so that is possible, from the comfort settings. And from the prescription point of view, I suppose really it is how well they're doing on it and how well they tolerate it. So yes, there's tweaks made all the time.
Great, because that's the problem we have. the problem that we have are some of our patients are not wearing it early on because they're not comfortable with the mask. So
I think, maybe I didn't get that across well, I think the beauty of home setup is that we're there in their home setting with their family, with their carers. We have enough time to give them repeated trials on it, and we do get back to them quite quickly. So really, most of our patients do really well on it. Now, I don't have exact figures, and it is something we plan to audit, so we can give you feedback. But they really do take to it from these home setups. I previously worked with the IMNDA, and I attended one of the other national services, and they do still an acute setting. And certainly our uptake rate from home setups is considerably larger than what it was in the acute setting. And there's a paper to support that from that service, Walsh et al., 2021. So you will see that the patients that were set up remotely in their home setting tolerated the machine in the long term way more.
Anyone else here? Last question, I believe.
Thank you for the great presentation. My name is Mary Faye, and I'm a nurse from ALS Clinic, Vancouver. And my question to you is, do you have any suggestions for bulbar patients who cannot tolerate the BiPAP because of sialorrhea?
Oh, as frequently as last week, I came up with this issue. It's something we'll all occur when we're doing it. I suppose close interprofessional relationships, we're very fortunate in Ireland in that the palliative care service work very close with us. Our colleagues are currently, one of the AMPs is working to set up Botox service. We have access to great, I suppose, symptom management treatments for this, and we try getting on top of things. In my experience, and I'm 10 years working in this field now, people that totally fail it, even bulbar patients like you've mentioned with poor secretion management, they're definitely the trickiest. I have one patient that's jumping out in my head right now, and I think he's unlikely to tolerate it for anything more than very short periods. I work closely with palliative care to try and use appropriate medication to relax and try that. Great secretion management from a physio point of view, using our cough assist, appropriate education with the family. You know, that one patient that jumps out in my head, but that's really frequent. Apart from that, I think good team interprofessional work, all the multiple factors of controlling those sialorrhea, be it pharmacological, be it with physio, be it with good timing of use, good seating. I think that's really good around the patient I'm thinking of now. If he doesn't sit in his armchair, kind of semi-relaxed back, the minute he leans forwards, he gets pooling of secretions, and that pools into the mask. But we spent a long time, you know, use it beside the fire in your riser recliner chair where you're tilted back. The room is a little bit drier. All of those things that feed into it. I suppose, you know, being comfortable with managing the symptoms from your patients, it is an issue, but it's not something I see a lot. You know, it is something I see, but not that frequent. It's overcomable with good symptom management control.
All right, if there's any more questions, you're going to have to find Katie afterwards. But
thank you.
Thank you so much. It was very interesting and a great model.